diseases which go into other specialities. So I thought I'll do it reverse. People generally talk about मेरे को refer करो, मैं आपको refer कर दूँगा. So that's the reason for this topic. I'll go through the ocular signs and symptoms which reveal some systemic disorders, and they are generally very common ones. Some of them are very uncommon. So we'll try to just skip through all of these things. So as I told you how ocular signs and symptoms, they go through the systemic disorders. So we'll go ahead with that. Now, why does this happen? Why does eye actually come in such a conjunction with all the systems? I was trying to understand the reason. The reason is that it almost develops from all the three layers of the embryo. And that may be one of the things why it is related to almost all the systems, and you get in view of everything what is happening in the body. Now, obviously, they are the windows of our body. They are vital indicators of patient health, and sometimes they actually precede. So, ophthalmic presentations at times are the first presentations for the systemic disorders. And that may be a very important thing because we may diagnose something very early, which will help us in the time to treat the disease. Before I actually go through it, there are a lot of terms which I'm going to use, which are generally an ophthalmologist is acquainted, but as a other specialty person, you may not be aware or probably may confuse you. So I thought I'll just enumerate those things as well. So the anterior part of the eye, which has the cornea, the lens, cornea, and iris, these are called the anterior segments. So the front portion of the eye. When I call the posterior segment the fundus or the retina, all of these represent the retina, which is the back portion of the eye. The posterior segment is where the light falls. Also, to know going ahead, what about the abnormalities coming up? Well, we need to know first the normal. So this is how a normal retina looks like. You can see some of the optic disc there, the blood vessels which are coming, and the center portion, which is the dark portion here, that is the macula. That is where the light actually falls and you actually sense images. So now this is the whole spectrum of the eye and what are the ocular manifestations of systemic disorders. You can see there is so many connections to the eye, and this itself tells you that it's a vast topic. I have picked up very, very common ones, and we will go through that only. The reason for putting up this as a part is that when we are treating a patient, it is only a patient. It doesn't matter which specialty we are, which super specialty we are. At the end of the day, the problem needs to be solved, and that is what is most crucial. And for here, we require teamwork more than anything else. So how are we going to proceed? So we'll go through some case-based scenarios only, and how eye examination helps to diagnose. There is obviously multiplay of doctors coming in, some common and some uncommon disorders. I'll be mainly dealing with four of them: hypertension, some neuro-ophthalmic connections, diabetes, some autoimmune disorders, and I'll in the end summarize what we have gone through. So let's start. So this was the first case, 33-year-old male patient, no previous medical history, suddenly came with a loss of vision over a week without any other systemic illness, headache, symptom, nothing. Vision was 6/60, significantly lesser. The anterior segment examination showed no abnormality. The pupils were reacting, so that is something which is very important again. Always check the pupils if there is vision loss. The bilateral intraocular pressure was normal. And when we did a fundus photo or a fundus examination, we saw multiple hemorrhages. I've deliberately put the normal image below so that you can actually see where it is happening. And then the above image shows a lot of multiple hemorrhages in the retina, a lot of cotton wool spots. Those are basically bleeding spots healing after that time. And optic disc margins seem to be blurred. So indirectly what it's saying is that there's a lot of pressure from inside, and that is what is creating all these symptoms in the end. We also did have an angiography here, so it's just something that tells us there is bleeding. So the blood pressure was 220 by 114. So obviously, it is secondary hypertension. There was no ophthalmic management again. All I had to do was refer to a physician, and they did an ultrasound which was showing normal, smaller kidneys than normal, and the diagnosis was chronic renal disease, obviously not treated by me. And the patient went kidney transplantation, and the vision improved later on without any treatment from my side. So case 2, 13-year-old boy, again, acute painless blurriness of vision, intermittent throbbing headache. Now that was again something which gives you a clue. He had no history of redness, pain, no neurological deficit. Anterior segment examination was normal. Vision was again 6 by 60, not improving with glasses. So same scenario. Blood pressure was 200 by 110. Obviously, 13-year-old boy, we need to think something else. So I had to refer it to a pediatrician. They did an evaluation for that, and there was a mass above the kidney. Came out to be pheochromocytoma. So that's what happened. And obviously, it was treated by a pediatric surgeon. And the vision after 3 months of follow-up improved till 6/12. Again, no intervention from my side. Case 3. So here, that's pretty much a common case. You will see that probably everywhere. 55-year-old male patient, known case of hypertension, walk-in OPD, Chand for an eye checkup. No visual complaints. Normal vision, anterior segment was normal, and fundus is as shown. So it again shows multiple hemorrhages, not that extensive. Here the difference is that the optic disc margin is clear. So that means that it's not that severe. So what do we understand by grades of hypertension? So basically, any blood pressure rise, the first thing what happens in blood vessels is that it causes vasoconstriction. The next step would be there is some sclerotic changes, which can also be age-related. And then comes the phase where the blood pressure is still more and the vessels are not able to take the pressure. And that's when the bleeding starts in the retina. And then comes the choroidopathy, which is the behind structure of the eye, covering it. And finally, the optic disc comes swelling. So the grade 4 hypertension, which you see and must be knowing, is actually a medical emergency. We need to understand this thing. Rest of the things just tell us that it needs treatment. So here are the 4 grades. I just summarized it. At the end, you can obviously see a lot of hemorrhages again in the retina. So eye examination, basically, all these cases tell you that hypertensive retinopathy can sometimes be the first sign of a systemic issue. So the blood pressure, actually patient may not even have reached to the general physician, and you can still diagnose it. The grades of hypertension can obviously tell you the chronicity of the disease. Grade 4 hypertensive retinopathy, as I told you, is an emergency. This necessitates a retina examination in all hypertensive patients. Coming to some neuro-ophthalmic scenarios. So I'll take 2 cases together to just save time. 2 cases. Case 1, 34-year-old woman, 3 days of vision loss, accompanied by ocular pain while movement, no significant history, no systemic illness. Vision was good in the right eye. The left eye was counting fingers. There was pupillary defect and the color defect also. Anterior segment was normal, rest of the things in right eye. The fundus examination was right eye normal, left eye showed optic disc edema. I'll come to it when I show you the photograph. Case 2, similarly, 16-year-old, overweight, fuzzy vision, no pain, no visual blackouts. Vision was 6/9, not improving till 6/6. Color vision was okay, she was confused. There was no RAPD. Anterior segment was normal, rest of the things. Both eyes showed disc edema. So what I want you to differentiate here is that 2 things, pain as a symptom with the movement of the eye in the first case. Second case, there was no pain and there was no RAPD or query RAPD. Now coming to what is disc edema first of all. So the normal disc is on your one side, and the optic disc margins, which are very well defined, like a cup, it is not very defined in those optic disc edemas. So now case 2, both the cases showed disc edema. One was in one eye and the other was in both eyes. So now what was case 1 diagnosis? We thought it is optic neuritis. Generally it is unilateral. Imaging was done and IV methylprednisolone was given under neurologist or physician. And of course we need to rule out MS as a cause for that. Case 2 was actually raised ICT. MRI/LP puncture was done and acetozolamide was done, given by neurologist or physician. So both the cases, similar kind of disc edema. One was unilateral, the other was bilateral. Pain as a distinguishing factor. Both of them go for a different diagnosis. So case 3, 47-year-old gentleman, blurred vision 2 months in the left eye. He was also not very sure of it, diagnosed as some serious retinopathy elsewhere. 1 drop of nepafinec was given to him. We examined the patient, both eyes 6/6, grade 1 RAPD, color vision normal, contrast sensitivity was normal. So what is difference between the case 1, 2 and 3? Here all the examination is normal except one pupillary sign. My fundus examination was normal, so I was stuck. So what we do? Go ahead and do the field test for the perimetry. The perimetry is basically just mapping out your visual field, what you see on a paper, that's all. So it does by some machine and we map it out. So we show here, if you can see all the left side, it is blacked out on the below portion. That means the patient is not able to see the above portion, because light travels in the opposite direction. The front portion, the upper portion goes and projects it on the lower retina. The lower portion of the light projects into the upper retina. So what we understand from the perimetry grossly is that the upper retina is involved. We only know that much and nothing is showing in the fundus. So go ahead and do an MRI and we found a mass in the brain. And obviously, again, I can't do anything, so I just referred it to a neurosurgeon. This is just to show where all the lesions can happen. And primarily, both eye involvement means it is beyond optical chiasma. So diabetes, again, we'll move on to this one. Case 1, 33-year-old healthcare worker went on to the optical shop for a blurred vision for 1 week, referred for no improvement in vision. Both eyes were 6/18, less vision, anterior segment was normal. So this is what diabetes was showing, the fundus examination. Again, hemorrhages all over the retina and the optic disc here is normal. So referred for blood sugars and physician, again the blood sugar came out to be 281. For post meal was also increased and HbA1c as well. So what do I do? Probably type 1. So it was referred to a physician and treated accordingly. Other side of the story, just changing the age. 65-year-old male patient, regular checkup for glasses, no complaints whatsoever, no known systemic illness, and eye examination was normal. So this was the fundus camera photograph, and again showing the same picture. So we'll just go ahead with this. So what diabetic retinopathy patients sometimes can show up in an eye OPD for a routine checkup. No complaints whatsoever for the eyes, and we get these kind of pictures. Normal vision does not rule out diabetic retinopathy. You can have diabetic retinopathy even if you have a normal vision. The vision actually goes bad in the very late stages of diabetes, and that is what is the importance of checking the fundus for all the diabetic patients. So this autoimmune disorders we'll just discuss in short. 56-year-old female again came with a solitary nodule in the eye. Just 2 minutes. Intense photophobia, and obviously documented no previous history. Visual acuity was normal. Rest of the ocular eye was normal. So again, this was diagnosed as nodular scleritis, which has got autoimmune connection We referred it to a physician for a systemic evaluation. No systemic underlying cause was there, so blood investigation showed an high ESR, strongly positive RF factor. Obviously, systemic immunomodulators were given and topical steroids from my side, and the patient recovered. Case 2, 28-year-old male patient, IT professional, painful again, red eye, photophobia. So what is the picture? I'll just comment it. So this was some inflammation in the anterior segment of the eye, and the eye looks something like what you see in the lower picture. It shows circumcorneal congestion. Whenever you put it on a torch, you will also understand it starts from the cornea. It is not around the cornea. It just starts from the cornea. So that's how you will understand it is circumcorneal. Diagnosis was anterior uveitis, possibly recurrent because there was some history of redness in the past. We treated it with topical steroids and NSAIDs, but that's not where we should stop. So we went ahead and did a CBC, ESR and CRP mildly raised, RA factor negative, and it came out HLA-B27. So spondylizing arthritis, I obviously referred it to an orthopedician to go ahead with whatever evaluation was done, and he was treated. To sum it up, for autoimmune, recurrent anterior uveitis presents with systemic disorders which have asymptomatic or subtle signs. A reference to with a rheumatologist or a physician is a common thing. Full workup is essential by a physician. So I'll just end with this quiz. 35-year-old male patient, right-sided face pain around the eye, normal vision, normal retina, normal systemic illness, dull aching pain continuous. Spent 5 minutes describing the patient in wonderful English, and I spent 10 minutes asking for the patient for other relevant history. Can you guess what happened? Any guesses? So the patient had tooth extraction 5 days before and he was not taking painkillers. So this is for our dental friends. Sometimes the answer is actually very simple. So the grand summary is eye examination can reveal a systemic disorder. It can sometimes be the first presenting symptom. Proper referral and good communication between ophthalmologists and other physicians make the management outcomes better. Thank you very much for patience.